Yeah, hi, Lord Winston. Question, what's your opinion of the government's approach towards illegal drugs? What did you think of...
Illegal drugs?
Illegal drugs. Yeah, what was
I mean, by that, I take it you mean heroin and cannabis?
Yeah, I mean, what was your opinion of Ian
I think
Gilmore's...
it's balmy.
Yeah.
I think that, well, in my view, I don't think criminalizing drug abuse works. I think it makes more of a problem for our society, but there is a political issue, and of course we as scientists can only advise about the science. Now, what we can say about cannabis is that it probably has a trivial negative health effect compared with, for example, smoking or alcohol. In fact, there's every evidence to support that view. And therefore, if you're going to criminalize anything, you probably ought to criminalize drinking whiskey. And yet we don't. So I think one of the problems there is that there's a total failure of having a rational response. But one of the issues, of course, is in a democratic society, governments, to some extent, like to feel they represent the populace, and they need to be populist in how they approach things. And the story for so-called illegal drugs is so strong that people have very fixed views about how they should be regulated and criminalized. But I don't think there's any evidence that the legislation we have works very well. In fact, I think it probably works rather badly. I thought David Nutt made a good point when he was advising the government on drugs, but of course he overstepped the mark by talking about policy, which was not his remit.
Thanks.
Lord Winston, you talked about 75 checkpoints and creating a level of bureaucracy for the elderly hip patient that was coming in. Do you think the bureaucracy itself was a problem, or do you think it was the failure to adopt appropriate informatics?
Well, I think both, actually. I mean, I think, you know, I don't think, I think we've become so nervous with regard to governance that we don't, it doesn't actually prevent accidents from happening. You could argue it might even increase them. And certainly, in spite of the burgeoning governance, which really happened under the Labour government, mostly, from about 1995 onwards, the litigation costs in the health service have risen. They're about 10% of our total budget. So it's not actually helping in terms of litigation. I think that the bureaucracy has a fundamental problem of avoiding really treating people as people. And there is some support for this view. There's a very interesting, and it's not just confined to Britain. There's some work that's going on in Holland, in Netherlands, which shows that where they've videotaped interviews with doctor and patient over 20 or 30 years, and they've shown that over the last 2 or 3 decades, the quality of the conversation between doctor and patient has dramatically lessened, i.e. it's more businesslike, it's more associated with bureaucratic issues rather than listening to the patient's anxieties and responding to them. And I think that that is generally true in our health service too, and I think we should be doing much more about that. That, I thought, was a truly frightening example. The BMJ goes on to dissect out how you might want to look at the articles online. It's only from 2 weeks ago, so it's easy to find. But I think you know, it's an example of really where we've lost the plot, actually.
Lord Winston, I'm from Switzerland, and it was very interesting to listen to the situation you described here in the UK with healthcare. My parents both worked over 35 years in a hospital, and my mom still is, and what you just described is exactly what's happening there as well. So I'm very interested to hear your opinion in how can we return back to healthcare so that a nurse can take care of the patient rather than going through checklists, and a doctor almost has no time at all anymore to look after a patient?
Well, I think there are lots of things we need to question, and this will be quite controversial. But I would argue one of the issues is whether, in fact, a graduate course for nurses in every case is the right way forward to improve nursing quality. I think actually that's distanced the patient from the nurse to some extent. We now insist on these graduate courses, which have given nurses status, but we should have given them status in a different kind of, with different mechanisms. Secondly, one of the things that successive governments have done is to abolish state-enrolled nurses. We used to have nurses that were not to the same level of qualification, but were very much more involved with care on the ward. And I think that that is something which really needs to be looked at much more carefully. And then, of course, there is the issue of how you provide better nursing in the community. Now, actually, nursing in the community in Britain, in parts of Britain, is pretty good, actually. If we can keep more people at home, we would do better off. Because having people in their own surroundings when they're old means that they don't get disorientated, means they don't get hospital-acquired infection, means that they have some degree of autonomy. But the problem, of course, is that more and more social care is under threat because of finances. So to some extent, I think one has to say that there needs to be a clear idea that money probably should be spent in these areas much more. But I don't think that we're getting there with the governance procedures, which I think really get away from that. And I find it, in consequence, very worrying, for example, that elderly patients in hospital wards have less and less dignity. I mean, it's quite normal for somebody to call, not Mrs. Rose, but hello, Evelyn, how are you? And they're called by their first name, and their surname is forgotten completely. And there's a lack of respect and a lack of dignity which ensues. I think also we could have better structure in the community for supporting carers who actually look after elderly people at home. And that varies to some extent with the quality of local authorities. But certainly in Britain, I can't talk for outside Britain, but certainly in Britain, one of the issues has been that local authorities have been extremely strapped for cash, and that makes it much more difficult to do. So I think it means spending a certain amount more money on not very expensive salaries, but also, I think, reducing and increasing the number of nurses that are perhaps not so highly qualified, but are more dedicated to nursing. It is, I think, rather shocking that we've now given nurses this kind of ephemeral status of being senior nurses in management, but forgetting actually that that doesn't really help patients get better.
I've got one. Do you think our inability to justify animal testing has affected the perception of stem cell research?
Well, I published a paper in Cell some time ago which looked at stem cell biology and animal research. I don't think the two are quite the same. I mean, I think stem cell biology, there have been other issues which have affected it. It's been much more the question of the status of the human embryo, which hasn't been a problem in Britain. But there is no question that the hugely heavy hand of the legislation and the way it's implemented by the Home Office has prevented more and more young people from doing work which involves animal research. And it's understandable, you know, if you have a PhD student who comes in to do a new project, and it may be well animal-based, they then have to apply for a license, they have to go through a rigmarole. It will take almost the first year of their project to get that license. So, of course, for the average PhD student, the backbone of science in Britain, it doesn't make sense to do animal projects. So, in fact, to some extent, there's a failure, I think, to take up more animal research where it might be useful. And I know that from my own work, whilst this hasn't affected stem cell biology, it's certainly affected a lot of the physiological work that we do, or have done in the past, which is very humane stuff. It's not stuff where animals suffer at all. I mean, the work we're doing with pigs, these pigs are totally friendly to us after they've had an injection as they were before, because it's virtually painless. They don't have any major surgery. And I think you know, when you consider how we treat animals in some parts of the farming industry, we are paragons of virtue by comparison.
Okay, any more questions?
Winston, you mentioned that mammals, when they are not cared of, when they are young, when they are not groomed, that they are likely to experience brain damage at the later stage. Is there an established link between a lack of care in early stages of humans to criminality, sociopathologies, psychopathologies?
I don't think there are any good studies which have been done. There are studies which show, though, that failure of care, Professor Vivek Glover at the Genesis Research Trust has done some work which certainly argues that failure of care will have a consequence for children as they grow up later on, but not criminality. I mean, that hasn't been looked at because this work's not been going on for long enough. The trouble really is you need at least 15 years, I think, to work that out. And certainly the second generation obviously can't be looked at. Michael Meaney's work in Canada was very interesting. Michael Meaney looked at the effects of the big Ontario ice storm, which happened in 1998 or 1999 when eastern Ontario was largely obliterated by massively bad weather. 30,000 pylons were knocked down in winds and because of ice on the wires, and large numbers of houses were completely blacked out in sub-zero temperatures for up to 6 weeks. Some people were living off the remnants of the food they had because they couldn't shop. They were isolated in farming communities. And a number of people died of hypothermia. Others were admitted to hospital in with very serious illness. And several thousand people were cut off in local homesteads around Ontario. And amongst them were women who were pregnant. It turns out that if you were pregnant between 18 to 25 weeks, then your children, after birth at the age of 4, show less cognitive ability. Not after 26 weeks. So it's a narrow window. And this has been linked by Meaney to cortisol levels. It seems that cortisol may be the mediator here. So certainly anxiety and elevated cortisol levels may, during pregnancy, have an effect, but not throughout the entire pregnancy. Now, having said that, there's some evidence that changes in cortisol levels in mothers who've got children that they're feeding may make a difference to their status as well. And that work's been done in London. But it's not been as carefully controlled as Meaney's work, and I don't think much of it's yet been published. But sociopathology, criminality, serious cognitive disadvantages, those things have not been yet quantified. There is a study at the moment in Singapore, by the way, going on called the DISCO study, which is only about a year and a half old. But that's a longitudinal study of several thousand children, where they've been looking at the genetics, the epigenetics, a whole range of hormone levels, and they're doing a really detailed, regular assessment, including MRI, looking at their growth and so on. I think the DISCO study in 10 years' time may show some interesting observations.
Professor Winston, really enjoyed your presentation today. Just wondered if there was another series of The Child of Our Time coming soon, and if you could say a few words about that particular series.
Well, the trouble with Child of Our Time is that it may not be their idea, but it is the ownership of the BBC. And the problem with the BBC is that it's, dare I say it, in this well, shall I just say it? I think it's a dysfunctional organisation. And so, first of all, they don't tell me, in spite of repeated phone calls, whether they have any plans. I've been to see the channel controller, and he won't tell me whether they're going to do any more or not. We were planning to do some this year. We were planning to do some next year, following up these children. They're now going through puberty, because they're now 11, 12. And I think it would be a wonderful time to be filming them, and we're going to lose them if we don't go back very soon. So I'm a bit sad about the inactivity, but I have no control over the BBC or the way they decide to use their budget. But every time I go anywhere in this country, and sometimes overseas, I'm asked about Child of Our Time. And it's frustrating, because I feel completely unable to give the information. When I made a complaint about it publicly at the Chelsea Flower Show, of all places, in May, there was a Daily Mail journalist in hearing, and she splashed it on the second page of the newspaper. And the BBC rang me up saying, oh, of course we're doing Child of Our Time again, you know. You're talking nonsense. But of course, if you don't want to do it, we'll get somebody else to do it. But of course, I don't know. So it's a very strange organization, and it's quite distant from I think, the people who have the ideas. That's why, of course, I think it's finding it more and more difficult. I worry for that great institution, because it seems to me to be not very well led, and sometimes, not always, but certainly I haven't had a very good experience with them. Sad.
Hi, Professor Winston. Last week I had a GP appointment, and my GP spent the entire duration of the appointment typing up my symptoms on the computer. I found this quite distressing, because I felt, well, she's not really listening to me. She's just kind of typing everything that I'm saying parrot fashion. My question is, how much has the evolution of computers and technology affected this kind of bureaucracy problem? Is it going to get worse? And how would we go about trying to reverse
Was
this
it your
issue?
symptoms or your child's symptoms?
My symptoms.
Your symptoms?
Yeah.
And you didn't want them typed on the computer?
Well, it wasn't so much that I didn't want them typed on the computer. It was more a case of I'd rather she listened first, and then instead of typing everything parrot fashion.
Well, I've got 15 minutes before I go back to London if you want a consultation. Well, you're dead right. I mean, I couldn't agree more. I think it's massive, because it saves time to not look in your face, which is what's going to tell her far more about you than what she's writing down. And you know, when I was a medical student, can I tell you the story about Richard Asher? Richard Asher was one of these people who believed that people's faces were the most important diagnostic tool that he had access to. And Richard Asher was famous. This is Jane Asher's father, by the way. He was a consultant at a big London teaching hospital. And he was famous for being the medical consultant who could make spot diagnosis into an art form. And so he used to come in every Thursday, and the ward would be filled with new cases that his registrar had collected during the week. And he'd go around the ward looking at the patient in the face and saying, oh, diabetes, and then moving on to the next one. Yeah, that person's got heart disease, and so on. And his registrar got more and more frustrated by this. So one day he came across somebody in outpatients who didn't need to be admitted at all, but had a rare disease called scleroderma, which is an autoimmune disease which isn't very well understood. And it does have a slightly distinct facial resemblance if you look very carefully at the face of people with scleroderma. I don't think there's anybody in the room, but I wouldn't know. Anyway, his ward round was on Thursday morning, so the registrar said, look, you know, I wonder if you could do me a favor. If we bring you into hospital late tonight on Wednesday night, do you mind staying in overnight and coming in for the ward round tomorrow so that Dr. Asher could look at you? And the chap had nothing to do. He was unmarried. There was no television. So he came in, and at 10 to 9, when the consultant was due at 9 o'clock, the senior registrar came round and said, Dr. Asher will be here in 10 minutes. He said, look, Mr. Fortescue, do you mind lying in bed and just covering your face with your sheet so just the bridge of your nose is showing, and your forehead, and then your hair? And the man was happy to play ball. So he lay there with a sheet over his nose like this. And then 10 minutes later, Asher comes into the ward with his junior houseman, the senior houseman, junior registrar, middle grade registrar, and the senior registrar joins them. So this parade comes round and comes to the first bed, which is Mr. Fortescue's. And he says, "Ah, scleroderma," and walks on to the next bed. How he did it, I don't know. But you're absolutely right. I mean, it's very difficult, because if you complain to your GP, you know perfectly well that the possibility is that your general practitioner will see you as a troublesome patient. And it's a nonsense. It's just shocking that that happens in the health service. I'm really sorry, because I think that everybody in a health service which prides itself on being free at the point of entry, everybody has a right to having proper health care, and that must mean being listened to, not written about. And when somebody's writing down on a computer, they're not listening to you. So I absolutely deprecate that. And you know what I used to do in a clinic, and it used to be something which I did routinely. I never wrote while the patient was in the room. I always listened to them. I never wrote notes while they were there. I would wait till they'd gone, and then I'd write my notes afterwards. Now, that meant that my notes were less accurate, and it meant that my recollection was required, but it meant that the patient had my full attention. And I think that that's really important. I mean, I don't practice medicine now. I do a different sort of job at Imperial. But I still feel that there are two things that a doctor should be able to do. One is to give the patient their full attention whilst they're in the room. And secondly, should never give the impression that they're in a hurry. They should never look at their watch. They shouldn't look at the clock. And they shouldn't be trying to hurry them to move them on. Unfortunately, both those perceptions have radically changed in the modern health service. And I think it's disastrous for healthcare.
Thank you.
Okay, in the interest of time, I think we'll let you go, Lord Winston. Unless there's one more question? We'll make this the last one then, if that's okay.
Thanks for your talk. If you could change one thing in the NHS, what would it be?
If I could choose what?
Change one thing in the NHS, what would it be?
Well, I've mentioned listening already. I think really, you know, what I referred to at the beginning, the notion that when you come to a doctor in a health service, they are part of a group, that they are working as a firm, as a team, and they're all involved with your health care. So that when the house surgeon or the GP goes off to play golf or on holiday, that first of all, they're actually contactable and they will know what's happening to you, that there's follow-up in that respect, that there is continuity in your care. And secondly, that other people on that team know what he would have been thinking of and also would want to try to make sure that the conversation that the two of you have had is respected. To my mind, that's missing in the health service now, except in a few GP practices. It's not happening in hospitals anymore, and it's disastrous that it's not happening. So it's a good question, because it caused me to think about it. I think actually there's little else, I think, which is as important as... So this idea of patient choice is a nonsense. You know, what the government says with its bill, well, people can choose their doctor. How can you choose a doctor when you don't know how competent they are? And there's no way of knowing that without any kind of metrics. I mean, you know, a lot of you are statisticians, you know perfectly well how fatuous that is, that these sorts of figures don't mean anything. So really, it's that question of getting back to the trust element in that doctor-patient relationship, that nurse-doctor relationship, nurse-patient relationship as well. I think that those are things I would want to see changed. It's a cultural issue, not a finance one.
Okay. Thank you very much, Professor Lord Winston.